السلام عليكم ورحمة الله وبركاته جميعا. It is indeed my great honor to warmly welcome you all to another chapter of MENASO's Cerebrovascular Grand Round Webinar organized by the MENA Stroke Organization. It is endorsed by the World Stroke Organization and the American Stroke Association and supported by Boehringer Ingelheim and Medtronic. MENA Stroke Organization is a region-wide non-profit organization committed to a vision to reduce the overall stroke burden in the MENA region. Organizing the webinars, MENASO contributes to the comprehensive education to help the entire stroke community. The Cerebrovascular Grand Round Webinar is a unique platform that provides comprehensive education about stroke, its latest treatments and management. Today's webinar, we urge everybody to write down their questions in the chat box, and there will be a dedicated session for question and answers after the two lectures presented by our guest speaker. Today's webinar will be chaired by myself and my colleague, Dr. Isam Salih. He's a consultant neurologist at Medical City in Abu Dhabi. We can now start with our first speaker, Dr. Syed Irtiza Hussain, who will be talking about the relevance of the cerebral collateral circulation and ischemic stroke. Dr. Syed Irtiza Hussain is the chair of the Department of Neurology in the Neurological Institute at the Cleveland Clinic, Abu Dhabi. Dr. Hussain is a consultant neurologist with 17 years of experience in neurology. After completing his medical degree from Aga Khan University, he underwent extensive postgraduate training in the United States of America. He is an American board certified in neurology, vascular neurology, neurocritical care, and neuroendovascular surgery. So we can start our first webinar with Dr. Syed Irtiza right now.
Good evening, everyone. I'd first of all like to thank the MENASO organization and specifically Dr. Taleb and Dr. Sohail for their kind invitation for me to present today. Again, my name is Syed Irtiza Hussain. I'm a vascular neurologist and a neurointerventionalist at Cleveland Clinic, Abu Dhabi. Today, I've been asked to speak about the relevance of the cerebral collateral circulation in ischemic stroke. I have no disclosures. So let's define the cerebral collateral circulation. So it's a network of vascular channels that provide alternative routes for blood flow when the primary route fails. These alternative channels can be recruited suddenly in thromboembolic occlusions, most commonly seen by us in large vessel occlusions in cardioembolic stroke. But they can also be recruited slowly when you have hemodynamic compromise over time from progressive stenosis, as is seen in atherosclerotic disease. And then obviously, as most stroke neurologists know and interventionalists experience, these are two entities are on a continuum and there's overlap and both can occur concurrently. The biggest example of that is when you have tandem occlusions, extracranial ICA with thromboembolism, or intracranial MCA or basal artery occlusions related to ulcerated plaque, severe stenosis, and finally when the plaque ruptures at thrombosis. So we have recruitment of collaterals over time, but then suddenly we need to recruit more because of the acute occlusion. So let's define these intracranial collateral pathways. And I would like to reference Professor Liebeskin's landmark paper back in 2003 from the Stroke Journal, where he's done a very good job of defining these collaterals. And I highly recommend reading this paper. So we can divide them into the intracranial collaterals and further divide into A and B as depicted here. If you look at these different views, this is basically looking at the intracranial collaterals between predominantly leptomeningeal pathways and connections between the anterior and posterior circulation. You can have connections between the ICA and the PCA via the posterior communicating artery. There are MCA, ACA collaterals. There are PCA, MCA collaterals. And we also see PCA, ACA collaterals. Around the tectum, there could be collaterals between the PCA and the superior cerebellar arteries. And the collaterals through the cerebellar hemisphere between the different cerebellar arteries can be a robust source of collateral flow when we're dealing with basilar artery occlusions. And that's the same view in a frontal plane. And then outside of the leptomeningeal collaterals, obviously, is the circle of Willis, which, or as we say, arterial circle, or the circle at the base of the brain, which can help connect anteriorly with posteriorly and between left and right. And obviously, their presence can be variable depending on whether or not the connections of the anterior communicating artery or ACA are robust, or if the PCAs are fetal in origin so that the P1 segments are small. So these can be variable and can dictate, obviously, the outcome in stroke. What I would like to highlight is when you are dealing with ICA terminus occlusions and you have a significant clot burden, then we have to recognize that those type of clots may be potentially blocking off two of the main pathways when we look at the circle of Willis. So if we take out the PCOM and then obviously the A1 segment, then there is significant disruption of the collateral pathways. And obviously that's why ICA terminus occlusions have a poorer natural course. They are more severe disease. As far as extracranial collateral pathways are concerned, these are present, and they probably have more of a role when we're dealing with occlusions over time. But nevertheless, they can also have a role in acute occlusions, and sometimes are of relevance when vessels are sacrificed surgically or endovascularly. So as far as the extracranial collaterals are concerned, we have connections between the maxillary artery, the meningeal artery. There are branches then that are dural based that can connect with the ACA. And then from the occipital artery, connections to the mastoid and then parietal foramen. And one very important collateral pathway is obviously the ophthalmic, and the ophthalmic connections via the meningeal artery and furthermore anastomoses between maxillary, sphenopalatine, distal branches, and retrograde filling of ophthalmics can be of importance to the ethmoidals. So within the model of ischemic stroke, it's important to recognize what is the role of collateral flow. And then we come back to the classic model of where we're looking at an ischemic core, penumbra. And after the penumbra, we have an area of oligemia, and then obviously normal tissue. Classically, we've measured the cerebral blood flow in milliliters per 100 grams per minute of brain tissue. So the normal is 50 to 55. Area of oligemia is 25 to 35. Penumbra, 12 to 22. And then in the infarct core, less than 12. Historically, the notion has been as the infarct core is irreversibly damaged. And we are trying to prevent this infarct core from expanding in size by salvaging these areas. And this is the area that is dependent upon collateral flow. So it's important to understand that the presence of collaterals will influence infarct evolution over time. And most of my colleagues who deal with stroke have seen this in clinical practice, where you have patients that arrive within an hour or 2 hours and have extensive ischemic changes throughout the hemisphere. So patient A, as depicted here, you can see that there's an entire hemispheric wipeout in a patient with poor collaterals. And where you have poor collaterals, you've lost over 460 billion neurons per minute just in 2 hours to wipe this out. But then we have a similar patient with an MCA occlusion who has sequential MRs over time, and you can see that the expansion of the infarction is very, very slow. So obviously this is dependent upon good collaterals, and the rate per minute of neuronal loss or infarct growth is much lower when you look at the second patient. And so collaterals do influence how patients present acutely and what their overall outcome is going to be. So how can we image these collaterals? There are many modalities available. Historically, before the modern era of imaging, we used a xenon CT and PET scans and different types of MRI scans, TCD, SPECT, quantitative MRA, time of flight MRA, and CTA. But nowadays, within the modern era, we predominantly use these 4 modalities. As far as non-invasive imaging is concerned, we have CTA, looking collaterals on CTA on axial cuts. This can be static versus dynamic. By what we mean by that is multiphase CTA, where we have sequential pictures over time. And the overall literature seems to be moving in the direction of using dynamic CTA along with CT perfusion because of the ease of use. MR perfusion is obviously available and is carried out by centers that make most of their decision making based on MR. And then obviously the gold standard is digital subtraction angiography. So this is an example of multiphase CTA, where it's divided into good collaterals, intermediate collaterals, and poor collaterals. And over different times, you can see over different phases the extent of the collaterals. So we have a left M1 occlusion, and over the 3 phases, we continue to have filling of the left MCA circulation. In the intermediate collateral phase, we can see it's not as robust. And with poor collaterals, we can see that there's very slow delayed filling. And so that's how we can distinguish between the 3. DSA collaterals is well established, and there's a grading scale originally approved by the ASITN, and that is now used more or less ubiquitously, whereas there's grade 0, no collaterals visible to the ischemic site. And this is basically comparing to delayed venous phase. By the time the venous phase arrives, how many collaterals are filling in a retrograde fashion. Grade 1, there's slow collaterals to the periphery of the ischemic site with persistence of the defect. Grade 2 is rapid collaterals to the periphery of the ischemic site with some persistent ischemic defect. Grade 3, collaterals with slow but complete angiographic blood flow of the ischemic bed by the late venous phase. And grade 4 is complete and rapid collateral blood flow to the vascular bed in the entire ischemic territory by retrograde perfusion. And these are visible on digital subtraction angiogram when you carry out catheterizations. So as far as CTA and CTP is concerned, so multiphase CTA showing an occlusion and showing collateral flow, and then that in itself is helping us to see on the perfusion map, we can see how that corresponds to overall mismatch, where our CBF less than 30 is showing the ischemic core, but then we're seeing a significant area of hypoperfused as the Tmax greater than 6 seconds with a favorable mismatch volume. And so this is showing us that there's collateral flow to this area, good collaterals with significant mismatch, and that this patient would be ideal for reperfusion therapy. MR perfusion basically can be utilized against multimodal imaging with diffusion, weighted imaging for an assessment of the core, MRA to understand the occlusion, and then obviously using MR perfusion and Tmax maps. And specifically what has been shown to predict the status of collaterals in large vessel occlusion is something known as the HIR, or the hypoperfusion intensity ratio, where the volume of tissue that is critically hypoperfused or ischemic is taken as Tmax greater than 10 seconds. And you divide that by an oligemic tissue, which Tmax greater than 6 seconds. And so here you can see that the 6-second map, the volume is larger, the Tmax greater than 10 is smaller. So this would be somebody who is favorable for mechanical thrombectomy because they have good collaterals. Conversely, on the other side, we can see where there's a larger volume of Tmax and a much smaller volume overall of Tmax 6. And so a ratio that is smaller, so less than 0.4 seconds, is suggestive of good collateral flow and is useful for in selection of patients who would have favorable outcomes with mechanical thrombectomy. So we know how to measure this, but how do these collaterals measure up as far as the clinical state is concerned? And so we know that there's an influence of the DSA collateral flow on clinical state. So Marks et al. Published this paper in which when they published collateral score against NIH score, so patients with poorer collaterals have much higher NIH stroke scales. Likewise, when we look at they correlate that with the volume of Tmax greater than 6 seconds, patients with lower collateral scores have much higher volumes in this state. CTA collateral influence of infarct size in MRS has also been studied extensively, and this is a good paper by Seaman et al. That correlates this. And basically, when we look at the relation of infarct volumes to collateral grade as well as clinical outcome, we see that there's a strong correlation with the collateral grading. So the higher the collateral grade, the smaller the clinical, the final infarct volume, and then the NIH stroke scale. So CTA collateral influence on infarct size has been studied, as well as the clinical outcome by Seaman et al., and which is depicted in these graphs here. And what this basically again shows is that when the collateral grade is better in these patients, overall their clinical outcome is better. And this has been well studied and well described. So how about collaterals and reperfusion? So the conflicting reports in the literature may be related to the heterogeneous modalities of assessing collateral flow. But furthermore, it's important to recognize that the volume of infarction versus location of infarction influences in functional outcome too. So, and that may have a bearing on whether or not many of these studies have shown a good clinical outcome or not. Overall, if you think about it simplistically, we could kind of dichotomize the relationship between reperfusion and collaterals. What's intuitive is that if you have good collaterals in a large vessel occlusion and you have successful recanalization, the outcome should be good. Conversely, if you have a patient with poor collaterals and they are not reperfused, we believe that the outcome would be poor. And I think most of the literature does show that. Where there is conflicting data is that we have trials that have suggested, registries and trials that are suggestive that collateral status may or may not influence outcomes, whether or not the patient is reperfused or not reperfused successfully. And I think, again, a part of that does matter based on the location of where your final infarct volume is. So in this instance, where we had an M1 occlusion and the patient is successfully recanalized, and there's significant sparing of the final infarct volume, we do have a significant infarct within the basal nuclei and involving the internal capsule with some mild hemorrhagic conversion. So even though volumetrically the final infarct volume would be good, potentially the functional outcome is influenced by other factors, which is the location of the lesion, and obviously if there's any secondary complications. So collaterals are important, but are not the only determining factor. And a lot of the literature does show that. Bang et al. Actually showed this nicely, where they stratified patients based on whether they had poor collaterals on this end of this graph versus good collaterals. And in patients where there was poor collaterals, obviously the infarct core is much more larger. Yes, they can have some mismatch, but there isn't a whole lot of benign oligemia. Whereas when you look on the other end of the spectrum, overall, patients with good collaterals may have much smaller infarct cores, yet significant tissue with mismatch and oligemia. So how about collateral flow augmentation then? So this is an intense area of research. And yes, in this era of mechanical thrombectomy, obviously thrombolysis and mechanical thrombectomy, when we're dealing with large vessel occlusions, it's all about speed. It's all about assessing the patient quickly, making a decision, administering TPA if and when indicated, and then speeding off to the angiography suite to recanalize the vessel and reperfuse the tissue. But what about endeavors outside of thrombectomy or in the time building up to thrombectomy? Are there other endeavors? So this has been a lot of these treatments or potential factors that can influence outcome have been studied. Head positioning has been looked at. The head post trial failed to show any difference. But when we actually measured blood flow in these patients, yes, keeping the head down does improve blood flow to the ischemic tissue, but we have not been able to show that it influences outcome. Likewise, blood pressure. Stroke guidelines currently allow for permissive hypertension up to 220 by 120, at least in the American Heart Association stroke guidelines. And additionally, if there is thrombolysis, obviously it's less than 180 by 105. But there's been extensive area of research on whether inducing hypertension or permissive hypertension and acute occlusions can help. Within the era of thrombectomy, there's been extensive research into the influence of general anesthesia when we induce general anesthesia and its influence on MAP and what it does to cerebral perfusion and what it does to outcomes. And obviously, this is an area of intense research where we want to optimize collateral flow while we're leading up to mechanical thrombectomy. Volume status of patient, which again, hydration is key and is important. There's some landmark data from the early days of stroke where just delivery of a liter of normal saline had influence on infarct volume and clinical outcome. Recently, there's been a study of volume expanders and looking at albumin, which has been a negative trial. But these initiatives have failed to show clinical benefit. But when we look at overall blood flow, we believe that some of these factors may influence. And so, especially as we're getting ready for mechanical thrombectomy, focusing on blood pressure for perfusion and hydration status is important, but perhaps there's going to be more important role during and after the procedure. Finally, as far as medications are concerned, there's a lot of data about the role of statins and their influence on collaterals, which is obviously more relevant in patients who are previously on statins, who have underlying atherosclerosis. And there's some basic science research and clinical interest in the use of nitric oxide as something that can help improve collateral flow. But it's important to understand that when we are assessing collaterals, we have to look at collaterals over time. So if a patient presents to you right now with a large vessel occlusion, with significant clinical imaging mismatch or perfusion-based mismatch, that tells you that, okay, this patient is okay right now, the collaterals seem to be working right now, but there is risk that these will deteriorate over time. And we know from the natural course and the natural history of large vessel occlusions that patients with large vessel occlusions will deteriorate over time. So it's important to understand that collateral flow in acute large vessel occlusions is dynamic. It's influenced by other factors. And what is good now may not be good later. And this is of relevance in clinical practice when we look about patients with LVO who have a low NIH stroke scale. So historically, when we look at the pivotal trials for mechanical thrombectomy, some of the trials, especially Mr. Clean, MR Clean, included patients with very low NIH stroke scales. And it has been well documented that mechanical thrombectomy makes a difference across the whole spectrum of NIH. But some trials did exclude patients with low NIH stroke scales. And that's been an intense area of debate and research. What do you do with somebody who has a proximal MCA occlusion and low NIH stroke scale? Whether or not they get TPA, if they're within the window, they'll be thrombolized. If they're not within the window, what do you do in that scenario? Do you treat the occlusion? Do you take them now? Do you wait till they deteriorate? And that's an intense area of research. And a lot of the natural course of the disease that's been published by many colleagues is that a lot of patients with large vessel occlusions may deteriorate later, and that there's a window of opportunity to act now. So it's important to recognize the concept that yes, you have collaterals that are good right now at this moment in time, and that your infarct is small, but overall there is risk that this will change over time. And most recently, there's been a very nice paper on JAMA Neurology looking at this, and where in patients intended to be treated with IV TPA with large vessel occlusions and low NIH stroke scales, when they looked at what predicted early neurological deterioration secondary to ischemia, they only found two relationships. One was the site of occlusion, and the second was the thrombus length. And actually, collateral flow or collateral status did not have any influence. It was not able to predict who was going to deteriorate or wasn't going to deteriorate. And so that's where, yes, collaterals are important, but not the only determining factor. And as we know, that patients with proximal large occlusions or tandem occlusions or basilar occlusions, these are the patients that will deteriorate. And as it has been shown previously, that the longer the thrombus length, the probability of deterioration is higher. And this highlights the importance of recanalization and reperfusion of the ischemic tissue. So yes, the collateral status in the acute large vessel occlusion scenario is important, but is not the only predicting factor. And we have to really think about recanalization and reperfusion. So what is the final message? Collaterals preserve tissue in the acute ischemic model. We know that. Collaterals influence infarct growth and final infarct volume. However, it's successful reperfusion strategies that determine the final outcome. Finally, additional research is ongoing, and augmentation of collaterals to improve outcome is where a lot of the research is going to be done. As you all know, mechanical thrombectomy has been established as a treatment. We can open vessels and we can open them fast. The next frontier is what can we do to preserve tissue while between the decision making and the treatment, and how can we continue to promote flow and prevent secondary neuronal injury after reperfusion. And I think collateral flow and obviously a lot of basic science research that is being done is going to help assist us with looking at the influence of collaterals and neuroprotectants in these patients. So that concludes my talk here today. And once again, I thank you all for listening, and I thank MENASO for the opportunity. And I'm happy to take any questions when we're in the question and answer section. Thank you.
I'd like to introduce Dr. Muhammad Al-Kuwaiti. Dr. Al-Kuwaiti is a consultant neurologist in Tawam Hospital. He has more than 13 years experience in the field of neurology and vascular neurology. He's completed his residency program from McGill University in Montreal and followed by vascular neurology fellowship from the famous University of Minnesota. It is an honor and pleasure to introduce Muhammad Al-Kuwaiti, who will talk us in secondary prevention in stroke. Thank you, Dr. Al-Kuwaiti.
Okay, again, my name is Dr. Muhammad Al Khalifa. I'm a neurologist at Tawam Hospital. I'd like to thank the organizing committee for inviting me for this session. I'll be presenting on cryptogenic stroke, the term ESUS, and secondary stroke prevention. Okay, I have no disclosures for this session. My objectives, I'll be defining cryptogenic stroke and the term ESUS, approach to the diagnosis and the underlying cause of cryptogenic stroke, and the potential role of atrial fibrillation, atrial cardiopathy, and PFO. And finally, I'll speak about PFO closure and new guideline regarding this. So the definition, so cryptogenic stroke is an umbrella term. It's a stroke of unknown cause. However, it takes much more, it takes lacunar stroke and non-lacunar stroke, and cases who are not completely worked up. So the term ESUS was coined around 6 years ago to specifically define embolic stroke of undetermined source, a clot that traveled and patient had a comprehensive workup. This term was coined by Dr. Hart around 7 years ago. And it includes around 25% of stroke cases are actually cryptogenic, and around half of these are ESUS. If you look at the burden and features of ESUS patients, this is a pooled analysis of cryptogenic stroke cases or ESUS patients. And actually, these patients usually have a smaller stroke, NIH of 5, a median NIH of 5. Their age is around 65. This study says 65 is actually a younger age. However, this is a Western study, so you have to take this age carefully. And usually these cases have less risk factors. And the stroke, annualized stroke risk in these cases around 4.5%, which is not that high. And looking at the workup that we do for stroke patients, I found this great article at the New England Journal of Medicine by Professor Saver, where he defines the standard evaluation of stroke patients. So as you all know, the standard evaluation is, so after history and physical, we do the regular blood workup, cardiac ECG, 24-hour Holter monitor, cardiac imaging, looking at vessels in the head and the neck. These are the basic things that we do. However, if this workup is actually negative and it cannot explain the etiology of the stroke, you can move up further to an advanced evaluation, where you can ask for a hypercoagulable workup, you can ask for a prolonged cardiac monitor for up to a month as a non-invasive recorder. And also you can try looking for signs or of vasculitis, or trying to do a transcranial Doppler to see if there's any monitoring of emboli or emboli detection. However, if still you couldn't find the cause of the stroke, there's other things you can do. For example, you can look for occult cancer. You can further look into a prolonged cardiac monitor with a loop recorder that goes up for 3 years. And you can look at the structure of the heart by doing an MRI or a CT, and trying to get probably some patients will require CSF analysis. Probably some patient will require brain biopsy. Vasculitis, for example, there's suspicion of vasculitis. And then there's genetic testing. And some PFO cases you can also do Dopplers of the lower limbs and upper limbs. And you can also can do MR venous of the pelvis. So in terms of ESUS cases, the management recommendations right now is usually aggressive medical therapy and antiplatelet. There's no enough evidence that anticoagulation is beneficial. There was recent randomized controlled trials done, Navigate ESUS and Respect ESUS. So Navigate looked into a rivaroxaban, comparing it to aspirin in patients who have ESUS. And this study was stopped early on because of no benefit, and there's a higher chance of bleeding in patients on rivaroxaban. And dabigatran also did not show a benefit over the aspirin in the Respect ESUS trial. However, looking at the sub-analysis of these trials, you'll see that the etiologies, they included patients with ESUS. However, the patients were looking at sub-analysis of different etiologies. In these cases, there were some etiologies that favored anticoagulation, for example, left atrial enlargement, for example, or left ventricular disease. And usually patients who have atherosclerosis favors more aspirin. I include this diagram because ESUS is again another umbrella term. There's a lot of different etiologies that can lead to ESUS. However, we have to try to define the etiology to be able to coin the best therapy. So as you can see here, there's examples are like atrial cardiopathy, which is a new risk factor people are looking into, and prolonged cardiac monitor to look for further like a risk of AFib, or looking at the PFO status, looking at the aortic arch or cancer. So in this slide, I have different types of cardiac monitoring to detect AFib. And if you see, it starts with the simplest one, which is the ECG. And you see the percentage of detecting AFib with a simple ECG is up to 2.7%. However, in a stroke unit where you can do a telemetry, the percentage of detecting AFib goes up higher to up to around threefold to up to 7.6%. There was a study, Embrace study, Canadian study, 16 centers, where they compared Holter monitor for 24 hours and a mobile cardiac monitor, like a patch, non-invasive one, for 30 days. And there was significant difference in detection of AFib. So it was about up to 16% if you monitor for 30 days compared to around less than 5% if you monitor for 24 hours. So it's a significant difference. And there was a Crystal AF trial looking at cardiac loop recorders where AFib detection was up to 30% if you monitor for up to 3 years. These are diagrams, these are pictures of these recorders. So this is the regular Holter monitor. This is the non-invasive patch that can go up for a month. And this is the loop recorder that goes subcutaneously. And I'm just trying to show here that patients who have a higher CHAD score and patients who are older than 70, the risk of detecting AFib is much higher the more you monitor these cases. Coming to atrial cardiopathy. So the size of the left atrium matters. So in this graph, it shows here patients who have moderate to severe left atrial enlargement. They have a higher chance of developing cryptogenic stroke, cardioembolic stroke. And there's a recent study that is still ongoing called Arcadia, and it's comparing apixaban versus aspirin in patients who have atrial cardiopathy, and is defined in this study by doing three different tests by using an echo, using the serum NT-proBNP, and looking at the ECG, trying to measure the PTFV1. Hopefully in a few years, we'll have more answers. And PFO is a common risk factor. It's actually a common finding in the community. So up to 25% of the community will have a PFO. However, PFO prevalence in patients who have ESUS is much higher. It's going to go up to 45 or even 50% in some cases. And it's actually a tug of war between interventional cardiologists and stroke neurologists in the past. What should we do with the PFO? So I hope this time we have more answers now. So this is a transesophageal echo with and without Valsalva, showing the the bubbles crossing into the other side from the right to left. So PFO closure is done through a catheter, and it goes all the way up to the left atrium, and they deploy an umbrella-like structure that comes back and then sandwiches the septum, the PFO. Looks like a simple procedure. There was 3 major trials in 2012 and 13 that were actually negative. That didn't show any benefit in PFO closure versus medical therapy. And American Stroke Guideline actually in that 2014, a year later, came up saying that patients with cryptogenic stroke or TIA and PFO without evidence of DVT, the available data do not support a benefit for PFO closure. However, they only support PFO closure in patients who have risks of recurrent DVT or patients who have DVT and increased risk of another one. Later in 2017, there were 3 randomized controlled trials that were published. They were actually positive trials in PFO closure. And I won't go into detail, but these are the names of the trials and the patient number. And these are randomized prospective controlled trials, but they were open label. And looking at the data of these trials, so if you look at trials here are on the left side, and looking at the device closure versus the medical therapy, there was much less stroke in patients who had closure of the PFO compared to medical therapy. The absolute risk for recurrent stroke reduction for recurrent stroke was 3.3%. And this is a table where actually I borrowed from my colleague. It's an interesting table. You see up the first 3 rows are the negative trials, and the second 3 rows are the positive trials. I'm trying to see the difference in these trials in patient enrollment. You'll see that positive trials, they included patients who had ESUS, the ESUS embolic stroke of undetermined source, and had a complete workup. And they also looked at the same time, they looked at the anatomical variant of the PFO, looking at the shunt and looking at the atrial septal aneurysm. So as you know, there's always complications with procedures. So in this procedure specifically, their complications are AFib, and it's up to 4.6% risk of AFib And in many of these cases, AFib was actually a transient phenomenon. There's, and this, the closed trial published this, and they had only one case of atrial flutter and 2 of subventricular tachycardia, air embolism. And this is a stroke, 2021 stroke guideline. So for ESUS, they include this table here saying there's no benefit to anticoagulate ESUS patients. It's not recommended to anticoagulate patients who have ESUS. And there's no benefit on using ticagrelor. This is specifically defined in the new guideline. And looking at the stroke prevention recommendations in terms of PFO, there are new recommendations few weeks ago. And the first recommendation here is saying that the PFO closure have to be done in a jointly fashion with cardiology and trying to take into account the probability of a causal role for PFO. And they define patients should be between 18 to 60 years of age with non-lacunar ischemic stroke of undetermined cause, despite thorough evaluation, and a PFO with a high risk anatomical features. And it's reasonable, so it's reasonable to close this PFO with a transcatheter device. They actually included this flow chart in the guideline, which I find interesting and useful. So a young patient between 18 and 60 years of age presenting with an embolic stroke and PFO. So the first thing you need to do is you have to do a complete evaluation. So the evaluation is suggested here, including Dopplers of the upper and lower limbs and pelvic MRVs. And we already discussed this earlier on. And if there was no etiology defined, then you move on forward to a potential paradoxical embolism. So then you have to evaluate that the patient have an atrial septal aneurysm or large right to left shunt. So this is the anatomical high risk feature that the patient have to be able to say that he has a high risk PFO. And in such case, high risk PFO closure is reasonable. However, there is still factors that you might want to take into consideration, like looking at the rope score or looking at if the patient requires anticoagulation. And even if the patient have a PFO but doesn't have the high risk features, you can still try to, PFO closure is not well established. The benefit of it is not well established. However, you can always look at the risk by looking at the rope score, history of DVT, recurrent stroke. So in conclusion, I'd like to say cryptogenic stroke is a very common diagnosis after a stroke. Complete workup is necessary. And therapy is currently with antiplatelet unless specific etiology was identified. Prolonged cardiac monitoring, increased rates of detecting atrial fibrillation, and atrial cardiopathy as a potential risk factor for ESUS. And PFO closure is reasonable in the age of between 18 to 60 years old with patients who have ESUS, PFO with a high risk anatomical features, and trying to develop like a causal association and jointly with cardiology. Thank you. And at the end, I'd like to take this opportunity to invite everybody to Abu Dhabi Brain Conference, which will take place online from the 2nd to the 4th of September of this year. Thank you.
Okay, thank you very much, Dr. Muhammad, for this great presentation. Now we would like to start our question and answer session. Okay, we received lots of questions, by the way, but because of the limited time we have, I don't think we'll be able to answer all questions. We'll start with the first question to Dr. Saeed Artiza.
Sure.
Would you proceed with thrombectomy in an M2 occlusion with good collaterals and an NIH score of 5, which is less than 1 point for all clinical trials? Because their kickoff NIH was 6.
Of course, of course.
Yeah.
So it depends on obviously if it's disabling symptoms or not, status of TPA, if thrombolysis is on board. As of right now, the evidence is mainly for large vessel occlusions. Once we get into M2s, the proximal M2 is still considered by most interventionalists an extension of large vessel. And these patients can deteriorate, and sometimes they have significantly disabling symptoms. So if they're an NIH of 5, but they're aphasic and have motor weakness, I would entertain that, and I would take them for thrombectomy. But there are a lot of case series and registries. I think Dr. Raul Noguera's group, Diego Hausen's group from Emory University have published a good registry on medium vessel occlusions. And I think it has to be considered on a case-by-case basis. But by nature, if it's a disabling stroke, I end up taking these patients.
I think I tend to agree with you, depending on the, how devastating the symptoms the patient is presenting with, regardless of their NIH score and how distal the thrombus is. As you mentioned, if a patient is presenting with only aphasia will come with the low NIH score, but I think it's a very important thing to preserve in a patient who is presenting with such a problem, and you are able to, help him or save this, issue.
Yeah, I think we're looking for direction. Hopefully we'll have more direction in the years to come as we get more data on it. And hopefully the guidelines will reflect that. But the thrombectomy procedure has the newer devices are becoming safer, and we've developed a lot more experience with the devices that we can be more careful in the smaller branches now.
Yeah.
Thank you very much. I get the second question to Dr. Muhammad Al-Kuwaiti. I don't know if you could help with this question, Muhammad, is in the borderline in terms of age group. And the question is, do you have experience on BFO closure in younger/pediatric patient caused by non-lacunar stroke? And by young, I mean as young as 9, 10, or 23.
Okay, so in the trials that were published, the positive trials, they had cases between the age of 18 and 20. Me personally, I don't have, I have my cases that PFO closure, I had few actually, but they were in their 20s and 30s. Trying to have a complete workup for these cases. It's not only the PFO, it's not only the embolic stroke, but you have to do a comprehensive workup looking at different aspects, trying to define why the patient had this stroke, including prolonged cardiac monitor, including doing imaging of the lower limb and the upper limb venous system, looking for DVT, and looking also at the structure of the heart by doing an MRI, and even evaluating this PFO using TCD, or transcranial Dopplers, where you can define the severity of the shunt much better than a transesophageal echo. I think putting everything together and defining ESUS first before proceeding for a PFO closure.
Thank you. I guess some of the patient in both prospect study on closure are even younger group, some of them about 19 and 18. So some of the data may support approaching even younger group if the workup is done properly, obviously. Always a difficult question is related to the causation to the actual BFO itself. That often is a very difficult question. Thanks, Muhammad. Talib, you can take the second question.
Okay. So it's gonna be for Dr. Sayed again. Do you think that the treatment window can be further extended in the future based on collateral score, because most of the automated algorithms we have now will detect the core of the infarct and the penumbra, but I'm not aware about any algorithms or AI programs looking at the collateral score.
Yeah, so I mean, at this point in time, we have indirect markers of collateral scores. So like I presented the hypoperfusion intensity ratio on MR perfusion, and then obviously extrapolating CT perfusion. So in a way, I mean, you're using that as a marker, in some cases direct, in other cases indirect. But at this point in time, no, I'm not aware specifically of using AI for that in that particular scenario. But yes, we're already expanding the window. I mean, the window is up to 24 hours. And who's to say that the window should be only at 24 hours? I think one of my cases, which showed natural evolution of a stroke on MR over 7 days with a very, very small diffusion core. I showed a slide of that. Over 7 days, it was significantly small. So every patient has different collateral flow and different perfusion parameters. And so I think, yes, the window will expand. We're going to move away from a time-based paradigm to a tissue-based paradigm. And I think we're already well along the way. So yes, I think that's the future.
Thank you very much.
Thank you. Question to Muhammad. There's a lot part of the world which is still having developed thrombectomy or even thrombolysis surfaces. And I have a question from a few of the audience. What will be the best approach in terms of therapy when you don't have any access to intervention?
That question to me?
Yes.
So in terms of trying to get, trying to be part of a network where you can send your patients for intervention is always a good idea. Connecting yourself to a comprehensive stroke center or a primary stroke center where they can do all these procedures, including a PFO closure or thrombectomy, I mean, or TPA. Either connecting with them either by telephone or by telemedicine, by seeing the patient and treating the case through a camera. I think this is doable, especially in the low resource communities and patients who don't have, even thrombectomy, for example, can be done in the low resource communities by non-neurointerventionalists. Like it can be done by cardiology. In some counties, for example, there's also neurointerventional, the body neurointerventionalists. Sometimes they do these procedures if the neurointerventionalist is not available. And I think the question was very broad. Was thrombectomy, was TPA, was not PFO.
I think the question, Muhammad, along the line, what will be the best option available if you are told you have no option of thrombectomy or thrombolysis in somebody present with acute stroke due to large artery occlusion and you have no access at all? You just have medical therapy. What will be the best medical therapy? And I think he put the question about dual antiplatelets and whether there's a possible role for anticoagulation. And I think he put an IH of 5 and a large artery occlusion.
So usually in patients in acute stroke, there's no role for anticoagulation. It's a very high risk of bleeding. And dual antiplatelets is usually recommended for specific cases. It has to be a TIA or a small stroke or patient with intracranial stenosis. Patients who have large stroke or LV, usually patients who have LVO have large infarcts. And in these cases, using dual antiplatelets or anticoagulation might put the patient at risk of hemorrhage. And if you add Plavix to these cases, in many of these cases, they might need a PEG. And putting Plavix on board will delay the length of stay will increase. and will delay the procedure in some cases. But I would recommend trying to connect to a network where patient can be transferred for acute therapy.
Fantastic. Thank you very much, Muhammad. Taleb? Taleb, you're mute.
So, Dr. Sayed, I think we have a question regarding mechanical thrombectomy and collateral circulation. So,
Yes.
how can we predict the likelihood of reperfusion injury in patients undergoing mechanical thrombectomy, or even with thrombolysis? Any relation to collateral circulation?
Yes, so I mean, that basically, it pertains to the size of the core. So within the setting of acute occlusions, large vessel or small vessel, obviously the timing. So if we look at thrombolysis data and thrombolysis trials, it's based on age, size of the infarct, blood pressure control, underlying coagulopathy, hyperglycemia. So there are medical factors that definitely play a role. But volumetrically, the larger the size of the tissue. Within the era of mechanical thrombectomy, when we're doing perfusion imaging and we're looking at the size of the core, there's an estimate of that. Secondly, on angiography. So when we see that there are poor collaterals and the core is large, then the risk of reperfusion, hemorrhage, or injury does go up. And finally, there's some telltale signs after thrombectomy. So if we see early venous filling or deluxe hyperperfusion, every time I see that, I'm quite aggressive with lowering blood pressure. This is an area of research. There are ongoing trials where looking at this, where in patients with extreme strokes, large cores that have been excluded from prior trials, if they undergo thrombectomy, what is the risk of reperfusion? Also, what's the best blood pressure lowering strategy? So a lot of us intuitively will lower the blood pressure as soon as we recanalize and reperfuse the brain. We drop it less than 140 by 90. Some people are more aggressive, less than 130 by 80. What's the data on that? So we don't have level 1 evidence on that. A lot of it is extrapolated from registries and trials, but there are trials underway both on blood pressure and looking at large ischemic cores. So in a nutshell, yes, there are patient factors, there are blood pressure, coagulopathy, sugar, and there are angiographic factors and imaging factors that dictate this.
Thank you.
I have a final question to Dr. Muhammad. How long would you continue dual antiplatelets, the aspirin and clopidogrel, as in the EXPRESS trial? Is that for 3 months, for a year, or lifelong?
So it depends on the pathology, what we're treating. Dual antiplatelets, usually I prescribe it for TIA and small strokes following the CHANCE trial, up to 3 weeks, and you can go up to 1 month. The POINT trial have shown that you can go up to 3 months. However, there's a slightly increased risk of bleeding. So I would say 1 month, 3 weeks to 1 month for patients who have TIA or small stroke. However, if the patient has history of intracranial stenosis, there's many trials like the SAMPERS trial and the VSET, where they compared putting a stent versus dual antiplatelets and aggressive medical therapy. The medical therapy with dual antiplatelets for 3 months was better. So I would, for these cases, I will extend it for 3 months. Usually after 3 months, we don't have enough evidence to say you can continue further to a year or 6 months. So up to 3 months is where the evidence stops there, to my knowledge.
And Muhammad, for this question, as a personal extension to the question, in people with microbleeds on MRI scans, would you still go ahead and give dual antiplatelets, or will you be a little bit worried about the risk of secondary hemorrhage, even if they got extracranial atherosclerotic disease and they present with a TIA?
Usually stroke risk is upfront. It's in the first few weeks. So if I can get away with a few weeks of dual antiplatelets, I think the patient will benefit. So I might suggest it for maybe instead of doing a month, I can do it for a less period of time. Let's say for 10 days or 2 weeks or even a week overlap, because the stroke burden is usually at the beginning. Stroke risk, the highest stroke risk. And I tend to keep the patient at least on a single antiplatelets. It depends on how bad is the microbleeds. If there's any signs of amyloid angiopathy, that's another thing. And yeah, I try to give the patient the best possible prevention plan. If it's amyloid angiopathy, I try to stick to only a single agent, and sometimes I try to avoid antiplatelets in some cases. Blood pressure for severe amyloid angiopathy, blood pressure control is the way to go, I see. And however, there's some article where they recommend, they still recommend using antiplatelets. And in some cases, if there's AFib, I've seen patients who have history of, let's say, lobar hemorrhage, they still recommend you can still anticoagulate these cases if they have AFib and a history and stroke, but had a history of lobar hemorrhage in the past.
Fantastic. Thank you very much. Taleb?
Okay. I think I have a more generic question for Dr. Sayed. It's about blood pressure management for those patients coming with high blood pressure with either ischemic stroke or hemorrhagic stroke. What will be your target and how aggressive you will go down?
Okay, so I think for ischemic stroke, it's very clear. I mean, the stroke guidelines state that quite clearly. If there's thrombolysis, if TPA is on board, then we less than 185 by 105 is our threshold. Otherwise, permissive hypertension within the first 24 hours, up to 220 systolic. For intracerebral hemorrhage, right now in our practice, and again, guideline based, less than 160 by 90, aggressive lowering of blood pressure more than that has not really been shown to improve outcomes within the first 24 hours. Recanalization, reperfusion, which is outside of a guideline, we currently do less than 140 by 90. So that's it in a nutshell, but I would refer the person who's asking a question to the guidelines. It's very clear about what we should do for blood pressure.
Dr. Isam, do you have any questions?
Yeah, Dr. Sayed, what is your experience in the challenges facing us with basal artery and posterior circulation strokes in terms of using the CT perfusion and using various technologies in selecting this patient who will come delayed? Do you go for MR or do you still continue using your CT perfusion with the limitations?
Yeah, so we've moved towards MRI. So in the posterior fossa, as Dr. Isam is alluding to, we have very good CT angiography and collaterals, but it's such a small area that to generate perfusion maps is hard. You can get some perfusion maps of the cerebellum, the cerebellar hemispheres, but within the brainstem, it gets a little challenging. But for basilar artery circulation, if it's hyperacute within 6 hours, most of my colleagues and I will just take the patient. If it's longer than that, within 24 hours, we'll still take them, but we'd like to get a hyperacute MRI prior, because we just actually had one patient last week within 6 hours presented to us, but the pons was wiped out, completely wiped out. And then, those are patients that we could actually make worse with reperfusion hemorrhage. So I think MR is more reliable, and that too is to get an assessment of the extent of ischemia within the brainstem, to get an extent of the core. We don't really look towards perfusion in the posterior fossa as much.
Thank you very much.
You're welcome. I think we reached the end of our webinar for today. I would like to thank Dr. Syed Artiza Hussain, Dr. Muhammad Al Khalifa for their participation and enriching our webinar series. Also, I would like to thank my fellow colleague, Dr. Isam, Salih. Thank you very much. And to all attendees, I would like to thank you for attending this webinar. I mean, without you, this webinar series wouldn't be successful. And all of you, there was a question about the certificates. You will get your certificates by email, I believe. I think with your registration, you submitted your emails, and you will get it by email, inshallah. Okay. Thank you very much, all, and good night.
Thank you. Thank you all.
Thank you.